Thank you very much for this invitation to come and share our experience with the production of decision aids directly from clinical practice guidelines. Oh, you can see my slides. So by decision aids, I mean what is shown in this picture here. It's a bit small. It's from the user's guides in JAMA, which is the hope, I think, of everybody's in the room, is that we use evidence to actually affect practice. So not just only discuss the evidence together between us, evidence users, clinicians, but actually bring them in the clinical encounter and be able to discuss with patients. I don't have a financial conflict of interest. I'm involved in leadership of MAGIC, of BMJ RapidRex, and other activities that you've heard about in other plenaries. So this is an intellectual conflict of interest, and my enthusiasm may be in all of this. Here is what I'd like to talk to you about. It's a short summary of the next 15 minutes, is that the volume and complexity of the evidence published every day requires guidance. We as clinicians need guidance, and I'm sure I don't need to convince everybody in the room. Yet the majority of decisions in healthcare, and I'd like to discuss this, are not clear-cut. They require some degree of shared decision-making that can vary with the decision, with the context, but some degree is almost always needed. Therefore, we might argue, and this is my opinion, that tools for guidelines for clinicians and tools for shared decision-making could well go hand in hand, be produced together, be presented together in order to shift the way we look at evidence and possibly shift our attitudes. If we agree with this goal, then evidence authoring and publication platforms can help, because the idea as a clinician is not just to have 1 or 15 decision aids available for a few situations, but to be able to say, in whichever situation I face, can I have the evidence, can I bring it at the point of care, when relevant, when needed. So the volume of evidence, just this quick slide to remind us that there is 3,000 to 4,000 publications every day. It's massive, it's exponentially growing. About 100 randomized trials every day, more than 20 systematic reviews every day, to which we contribute here. For clinicians, how to stay up to date with this, how to detect what is trustworthy or not, I think Gordon Guide showed it again, is not possible without help. So yes, we need guidance, but most decisions in medicine are not clear-cut, and there are many ways to point at that. One is the study we conducted among probably the largest sample of grade recommendations. It comes from UpToDate. It's not a guideline institution, but it covers a large coverage of clinical questions. And we found out that 1/3 of the recommendations, only 1/3 is strong in this context with their methodology, and as many as 2/3 are weak recommendations. Now, I work as an internist, and maybe other clinicians would know that patients are sicker than what the evidence includes. For our real patients, the evidence is often a little indirect or very indirect. So when I'm facing a patient, even with a strong recommendation, this might actually morph into a weaker recommendations before the context. So regardless of strong versus weak, we as guideline makers need to do our job. In real life, some degree of shared decision-making is needed, some contextualization is needed. A reason we might want to consider producing guidelines and decision aids, tools for shared decision-making together, is also because of the challenges that we share in these communities. They are time-consuming to produce. We don't have efficient authoring strategies most of the time. We can make better. We duplicate efforts, as we discuss often here. We are not well disseminated in both silos. Knowledge translation efforts are not at full capacity. We haven't found the magic solution yet. And most of the formats we developed are to meet educational needs. They don't go as far as be able to actually face patients. And finally, everything is expensive. The production, the update, things are rapidly updated with the volume of evidence, so this is a lot of money and efforts to put at. So why not produce them together? Another reason is the efforts that our communities try to make in bridging the silos, working together in this evidence ecosystem. So how to have a better flow of data from producers, synthesizers, disseminators, let us call us that, to clinicians and patients, implementers, etc. If we want to do that, data has to flow better. And this is where I think the authoring and publication platforms can help. Our experience, and others are working on that too, is with the Magic App. Magic App is an authoring platform on a first side where guideline makers, systematic reviewers can structure their content in a tagged format, digital format, which can then be reused in many, many ways, and that's the publication aspect of it. Firstly, we, of course, try to produce formats for educational needs, dissemination of guidelines. We can integrate them in electronic health records, and by them I mean bits and pieces of it, as Lynn Brandt showed in the open plenary. We can adapt the data. We can take, for example, a Canadian opioid guideline in Europe and just see what needs to be changed. And this is the last part of this slide. We can also use all of that to create those tools for clinical encounters. There are many types of decision aids, and it's not the purpose to analyze them all, but traditionally they were used by patients alone, designed to be used by patients alone to empower them, to prepare them for a clinical encounter. Probably if we want to bridge with guidelines, it's more about consultation decision aids that might be needed, things that I can really take from the guideline and come at the point of care. But even those consultation guidelines are of two kinds. You can design them in a very specific way, and many do that. There are hundreds of decision aids now, beautiful decision aids. Here from the Mayo Clinic, from Victor Montori, a decision aid on diabetes, choice for diabetic medication. They're beautiful, but they're very, very specific. Their design is very specific to that question, that context. And another decision aid might look completely different. So if we want to speak of automatic production, we need probably a more generic approach to anticipate what elements we need to have structured data so that the system can ask you for those elements in order to produce the decision aid. And that's how they can be automatically produced, updated, and shared. So of course, sharing is a decision. You need to have an open API to be able to integrate that in different systems. So specific versus generic. In our approach, in this project called Share It, in Magic, we aimed for a generic approach. In this paper in the BMJ, we explain how we went for a user-centered design. We start with prototyping it, but we go with real clinical encounters and decision-making, and we test, we observe what happens with different versions of the tool. We interview patients and clinicians, and we modify the tool again. We will not arrive, and we have not arrived at any perfect format, but a format that is compatible enough with different conditions and situations. And it can be shown on iPads and computers at the point of care. So this is the method. Now let's see how we can bridge it with the production of guidelines. And I'll use as an example one of our guidelines in Magic. We have a steering group that collaborated with the BMJ to produce the rapid recommendation. You've heard about them. We monitor evidence. We pick and choose with the journal very interesting topics, practice-changing topics, and we try to explore formats to convey the message. And I'll show you our decision aids linked to this guideline. It's our latest rapid rec on prostate cancer screening with PSA. It just came out last week, so I invite you to have a look and give us feedback. And you see that you have additional formats feeding from these platforms, infographics that we co-developed with the BMJ that shows the balance of benefits and harms, practical implications. And within those infographics, we've embedded our links to Magic App, which lead you, first they can bring up pop-up windows about more detailed information from the platform, full summary of finding tables following grade, but also the decision aids. So here is one of the decision aid linked to this guideline. You observe that the first layer is not that fancy, no numbers, nothing. Just a simple trigger question. What would you like to discuss first or next with the patient? And just the issues, the outcomes that turned out to be in the guideline, or a selection of them reworded. Maybe we're considering screening to avoid dying from prostate cancer, to detect cancer, localized, advanced. Maybe we're worried about complications, or we would like to know practical issues related to doing screening or not. Shall I have a biopsy? What is a biopsy? What are the implications of doing all of this? So you see the ingredients here in a generic format of the decision aids. The patient might choose to talk about one or the other. The order might vary. In our testing, they never look at everything. As in other research in decision aids, patients and clinicians choose what they talk about. And they can dive into more information about each outcome, each issue. Here, for example, pictographic formats. Among 1,000 patients like you, without screening, there will be about 3 of the patients who die in 10 years from prostate cancer. By doing screening, this is 1 fewer deaths. One patient avoids dying from prostate cancer. All the others do not. So different formats that we know can help communicate risk. Or we can stay at less deeper layers of communication and playing with cards, looking at different outcomes and issues in numerical or text format. There would be, for example, 25 more erectile disorders due to screening, 3 more severe incontinence, and you can put that in light with the other outcomes, and you see the conversational aspect of browsing this evidence. It's not just a summary, a table, it's something you interact with and that supports a discussion. What the testing showed is that we also need practical information. And for example, option grids, which is another way of producing consultation decision aids, know that patients are very interested in frequent questions. And those questions are often very practical. So in a project that is soon to be published, we mapped patient experiences in healthtalk.org, so a large sample of patient experience. And the idea, again, is to be generic, is to say what are they talking about, what type of information are they conveying, so that we can structure it in the authoring and publication platform. Here you come with 15 categories, such as medication routine, procedures, but also the last line, which is real life, my diet, the impact on my exercise and activity, social life, travels, etc. So patients talk about all that. This comes from what they say. And if we structure that information in an authoring platform, then it can be reused in presenting the data. And the idea is not to populate it with massive information, but just bits and pieces of information that can support the conversation. We've tested that it can also remain empty. This is not ideal, but in testing, patients were looking at an empty icon about social life or exercise, and suddenly the discussion turned around it. The shared decision-making turned around the exercise that the clinician was not aware of because we were too focused on other aspects of the evidence or of outcomes. So things seem to complement each other in testing. Patients also ask to have printed formats to be able to share this with their close ones, their loved ones. So we are now developing printing functionalities for this. And that's an ongoing research because if the database is well structured, you can produce new formats. For example, in our research now, we look at how you can compare multiple options. Another challenge in generic production of decision aids. Here we have a snapshot of a prototype about chemotherapy for lung cancer. You have lots of different chemotherapies implications. How do you produce generic formats of a similar kind? And this is what we try to do. So now just to end up, what is our experience with the scaling up? How many decision aids you can produce with that approach? MAGIC is used by about 1,000 users, but actively by 38 institutions, like many here. And they produce so far 102 public guidelines. And so I recently counted them. There are more than 100 PICO and grade recommendations in that sample, and about 600 active decision aids. So decision aids, when we look at them, produced by someone else, not us in MAGIC, through the platform, you see that it's not all PICO. Sometimes the PICO is not relevant to an immediate clinical decision, and the users can deactivate it, the guideline makers. And so this gives us an idea of the volume when real guideline making is done, of when a decision aid might be produced. There is no distinction between strong or weak recommendations. I know it's a debate on Twitter right now about whether we should focus our efforts on one or the other. If we have such strategy, this is almost a non-issue. And again, it's the way we orient towards the evidence, whether it shifts our perspective towards behaviors of shared decision-making. In RapidRex, to finish my counting, the context where we control in our group the guideline making completely, we produce 32 decision aids accessible through those infographic formats, and we welcome feedback on them. So in conclusion, I hope I showed you at least that as a proof of concept, tools for shared decision making can be produced from guidelines directly, hand in hand, that such platforms and others can help scale it up, that our preliminary evaluation of this in user testing is that patients and clinicians are quite happy in using it. It does shift the behavior a little. And an interesting anecdote is that even experienced clinicians who master the evidence in a field, when they look at it in those different formats, sometimes they also slightly change their minds. There's certainty about something, and I hope this is also an ingredient for shared decision making. The future is always, how can we implement this at a large scale, how we can actually make people use guidelines, decision aids, so we don't have solutions for that, but this is what we should aim for. Thank you for your attention.